everyone. We are looking forward to having a very vibrant discussion and dialogue around medical dental integration. So it would not be me if I did not recognize our rural NRT response team, whereby we've got some main goals, folks. As a part of the open membership network, we have been working all around looking at advocacy and education opportunities to promote rural oral health, highlighting really good strategies that folks have found that have worked in their communities, and promoting different things such as data collection efforts to better understand what's going on in our rural communities and how we can continue to serve and partner with them. Few housekeeping rules. So if we are not the main primary folks speaking, we would truly appreciate the mute button to be on. That's that mic that has a red slash through it. We also want to make sure that we recognize any questions or concerns or comments. The chat box is our friend today. We will be using our Zoom chat box for all things. As many of you know, Ian is making its course. My empathy and sympathy to any family, friends, or coworkers that may be in the line of sight currently and within the past few days. So we're excited to be here, but we want to be safe. And so with that being said, we're going to keep it basic and use the chat for any discussion features. And we also want to let you know that if things go awry, things are being recorded. If we get a blank screen, folks, we're gonna take cover and make sure everyone is doing well and regroup with communication at a later time. So we'll make sure that things are sent out to you. That kind of completes our housekeeping. And I've asked everyone to kind of throw in the chat box who they are and where they're from. We've got some folks from Oregon, Pennsylvania, South Carolina. We got some representatives from different coalitions and some of our rural NRT folks, and we see some other partners from NRHA and Open. So we are excited to have a diverse set of folks joining today. We had a good bit of folks register and still some folks being admitted into our conversation today. So we'll keep this kind of train going. If you haven't thrown in there whom you are and what entity and state you're from, feel free to do that throughout our time. But in keeping with efficiency, for those of you who know me and my facilitation of things, I want to get us right to the point. So here's what we're doing. We are just welcoming, kicking ourselves off, and then we're going to ground our conversation today with our panel speakers. We have Ms. Kelly Braun and then Dr. Amy Martin, and they will provide the best commentary about whom they are and what they do. So I will allow them to go ahead and do their introductions at a point in time there in our grounding conversation. And they're going to share some of their line of work and how they've seen lessons learned and challenges around medical dental integration with some of the experiences that they have had. Then we're going to go into our discussion. And our discussion is going to be pretty open. So there are some prompts that Kelly and Amy will respond to, which will be great. And we want to spin those prompts into any other comments or questions or things that folks want to bring before the group and or ask Amy or Kelly about during that time. And then we'll close out our time together and we'll share some upcoming roundtables with you, as this is the beginning of 3. So I will go ahead and begin with grounding our discussion. We have Kelly Braun from the Pennsylvania Office of Rural Health. And I'm going to turn it over to you, Kelly, to give us a little bit of introduction of who you are and what you do, and then rolling straight into your time with us, Kelly.
Perfect. Thanks, Joni. So thank you all for joining today. My name is Kelly Brown. I work for the Pennsylvania Office of Rural Health. We are one of 50 state offices of rural health. So basically, every state has one. The way that each state has theirs kind of set up or established can vary. Ours is actually university based. So we are on Penn State's main campus here in central Pennsylvania. And several years ago, when I started with the office, so about 6.5 years ago now, we actually started working on medical dental integration. So Joni, if you want to just kind of jump into my slides here, we'll just go ahead and get started. So just a quick overview of sort of what the past 6.5 years have looked like for us in Pennsylvania, kind of a little bit of an overview in terms of current landscape. This also is sort of over the past 6 years as well. But we know right now, one of the big things we're talking about in Pennsylvania, and I don't think this is just a Pennsylvania thing, I think this is a United States thing, dental workforce shortages. So not just dentists, but also dental staff shortages, shortages of dental hygienists, dental assistants. This was sort of starting to, get bad before COVID. Like we needed more dentists prior to COVID. It's been further compounded by COVID. So those that were maybe nearing retirement age just sort of called it quits. They may have worked another couple of years. But with all of the extra PPE, extra expense, all of the things, we saw a lot of offices close through COVID that we may have had around for another few years. So workforce is definitely a challenge. We know our focus in our office is rural Pennsylvania, which is actually quite a vast portion of Pennsylvania. And rural residents need to travel further to access dental care. So there are a couple of compounding factors there: transportation and access to transportation to be able to get to those dental appointments, dental insurance, finding a dental provider who will, accept new patients and participate with a patient's insurance plan. And then the time off from work or school in order to be able to travel to those dental appointments is also very challenging for many rural residents. And then we know that, children often will see their pediatrician or their primary care provider more frequently than a dental provider, especially in those first few years of life. And so as we started medical dental integration in Pennsylvania, it made sense to start in rural areas and to start with children who were likely seeing their primary care medical providers more often than they were seeing a dental provider. So in 2016, we partnered with what was the DentaQuest Institute at the time. They're now known as CareQuest. And we brought more care. So that's an acronym for Medical Oral Expanded Care to Pennsylvania. We ended up with 2 cohorts of clinics. So our first year, we had 9 clinics on board, and those 9 clinics are actually depicted on the map that's on this slide. In the second year, we added another cohort, and those clinics were down sort of Carbon and Schuylkill County. So if you go to the left side of the screen there, kind of those bottom bright green counties were the 2 counties that we continued working in as we sort of went through a second year of this program. All of the clinics that participated, so there were 13 total, are still integrating dental into their primary care practice in some capacity. So it may not look exactly like it did when we first went through this these learning sessions and this collaborative project, but still definitely, doing things like fluoride varnish and having conversations around oral health. 2 of our clinics down in that Carbon Schuylkill County, that southern, southeastern portion of the state, they have a rural residency program. So they bring in medical residents each year, and they are there for a total of 3 years, learning sort of rural primary care medicine. And every year I still go out and do training for those residents about oral health and sort of help them to start to integrate it in their practice during the time that they're spending in their residency. Our hope is that once they leave that residency, they take that into their primary care practice as well. So we worked on integrating oral health risk assessments into medical visits, oral health self-management goals based upon those risk assessments, and then fluoride varnish as well. In Pennsylvania, the medical providers can apply fluoride varnish as well as the dental providers. Medical provider applying it, it gets billed to medical insurance. Dental provider applies it, gets billed to dental insurance. So we didn't have any problems with Well, the dentist just put it on 2 weeks ago, so I don't know if we'll get reimbursed. It's totally separate. So as long as that child's documented as high risk, the medical provider can put the fluoride varnish on up to 4 times a year. As these clinics we were working with were rural health clinics, they actually didn't see, at least on the Medicaid side, they didn't see any additional reimbursement for integrating oral health into their practice. So it became part of what they did to care for the whole patient. And we knew that if we could make this work in a rural health clinic where there weren't necessarily always ties to additional reimbursement, then we could in theory make it work anywhere. The other piece of this, in addition to integrating care into primary care practices, was actually coordinating care with dental offices. And so we not only wanted the medical providers to be focused on oral health with their patients, but if that patient hadn't seen a dentist or didn't have a dental home established, we really wanted that medical office to work on that with the patient. And so we ended up working on referrals to dental providers and then working with those dental offices to try to get a treatment report back. Just like if a primary care provider sends somebody out, gives them a referral to an endocrinologist, that endocrinologist writes back to the primary care provider to sort of discuss their findings. We wanted that same thing to happen. So we had the opportunity to actually have a few of these clinics take things a step further about 3 years ago. So right before COVID struck, we actually ended up getting some HRSA funds, and that was a statewide HRSA grant. And our office was fortunate to be a part of that. With that statewide HRSA grant, there was some money set aside for rural health clinics to actually integrate oral health into their practice. So now taking it a step beyond the medical provider talking about oral health and going to actually having a dental provider embedded in the rural health clinic. So not only could the patient come in and receive primary medical care, but also some primary dental care services as well. This picture was taken in one of our partner clinics, and it's the portable dental equipment that they were able to purchase with the grant funding. They actually literally kind of cleared space in one of the medical exam rooms. So they pushed aside the medical exam table, brought in the dental chair and dental equipment, and they hired a public health dental hygiene practitioner. And that is something that is sort of unique to Pennsylvania, not quite mid-level, but more of an independent provider. And they're able to practice in rural health clinics. That's one of the allowable settings. And so the facility was able to hire that individual and start doing preventive dental visits, especially coordinating while they had a patient in the office for those medical visits as well. With that, they actually found a great need. So they started uncovering a lot of decay, a lot of need for extractions, restorations, and they were having a hard time getting those patients into other facilities. And so they have now hired a part-time dentist to actually staff that facility as well. So I'm probably way over my 5 minutes. I'm going to stop and let Amy share, but happy to entertain questions later during the roundtable, or my contact information is here. Always happy to have a conversation with folks as well. So thank you.
And Amy, I am going to invite you to dovetail right behind Kelly. If anybody has any burning questions, we are going to make full use and put a lot of mileage on our chat box. So I'm going to invite you to do that now. And Amy, I'm going to give you the floor. And if you could give us a little intro into whom you are and your work.
Okay, and I'm so sorry, but if you heard a very loud sound, that's the hurricane warning from the National Weather Service going off on my cell phone. And so my apologies. Greetings from Charleston, where we are on hurricane watch officially. And it is appropriate that I follow Kelly because she has just been a fantastic advisor to us as we too have tried to figure out what does a co-location model in primary care look like for South Carolina. Very, very different states with regards to Medicaid reimbursement and how dental benefits are organized and delivered. So we have tried to learn from Kelly's model and figure out how do we structure it so that it fits into a new model for South Carolina. And I am on faculty at the Medical University of South Carolina, where I serve as department chair and professor, and get to work alongside the wonderful Dr. Joni Nelson. In addition to being in Charleston, though, we spend much of our time canvassing rural South Carolina. So I wanted to lead in and talk about a specific demonstration concept that Kelly advised us on. And it was a little different in that we didn't start with policy drivers at a statewide level. We actually started at the community level. So Marion County is the bedrock of the tobacco industry historically in our state, and is a very rural area with a lot of oral health inequities, especially for children. So we have designed and are pilot testing a system, a new rural pediatric oral health system that includes school-based programs, community health centers, community private practice dentists, as well as a new integrated model that we're calling the COIN. And the COIN is an acronym for Community Oral Health Integration and Navigation. And the COIN sits in the bottom left bubble of the MUSC integrated hygiene team. We have hired a hygienist, much like Kelly, and we have co-located her inside a pediatric rural health clinic. We have, as a healthcare system, MUSC as a healthcare system, we have purchased a number of rural hospitals and acquired a vast network of rural health clinics. So we are pilot testing this in Marion in hopes of deploying it and replicating it across our system, as well as advising other healthcare systems across rural South Carolina. In addition to the integration model, we're also trying to figure out how can we bring in value-added components, such as surgical rotations from our pediatric dental residency program that we have here in Charleston. We only have one dental school, and of course it's on the edge of the state, and we're trying to figure out how to deploy those resources in value-added ways to our rural communities. But I would like to use my time to focus on the COIN, the Community Oral Health Integration Navigator. And I thought I would start with some lessons learned. We're really in the formative stages of this. As we were just getting ramped up, COVID hit our state especially hard, given how the rural Southeast was especially plagued. We couldn't hire a dentist if we grew one ourselves, or rather a hygienist if we grew one ourselves. So we had a real recruitment problem. The other is our pediatric rural health clinic partners became trepidatious about doing anything in the oral cavity when we still didn't completely understand how to mitigate viral transmission in a clinic setting. So we rather spent our time researching and seeking counsel from folks like Kelly and thinking about our playbook. We have finally put things into action. We have hired the absolute right person, and under the bucket of lessons learned, we hired a hygienist who was born and raised in Marion, left to North Carolina to seek her college education, and came back because she loves her community and wanted to really do something of great value in her home community. So hiring the right person is essential. It is especially helpful when you've got someone indigenous to the community, and our hygienist absolutely is that. From a skill set perspective, she has completed the ADA's Community Dental Health Coordination Curriculum. So she's one of us. She thinks beyond chairside hygiene and really even beyond community-based hygiene clinical services, and really does see the whole field, the whole system, making her an ideal model coin for our state, because we're still documenting what this looks like from a practice and a policy perspective. Some other important points as we have gone about launching our model is the importance of having a quality improvement culture. As we identified the rural health clinic that we're working in, which is a pediatric practice where we're targeting pediatrics and family medicine RHCs in this model. We purchased a hospital that was previously owned by a for-profit entity. And for better, worse, or indifferent, the clinical team in the RHCs that we're talking to really don't have that culture. So while we were blazed and ready to go and promote what we know to work with oral health integration models, it occurred to us that we had to take two big steps in reverse and focus on quality improvement from the perspective of conferring skills and doing training and investing in the RHC team on what quality improvement looks like and how to carry it out, while also simultaneously cultivating a QI culture in the practice in partnership with them, so that they had a good sense of how to observe process, think about how to improve process, and do it through the lens of a framework and a playbook. The good news about our RHC partner is they intuitively understand that. They have had a strong commit to quality. The medical director there is fantastic, but they had never been equipped with a framework and a structure for carrying out what they intuitively knew to be good practice. So we had to take a step back. We have a library, or almost a portfolio of PDSAs, Plan, Do, Study, Act worksheets that focus in 3 domains. So we have a body of PDSAs that focus on clinical services that get at the clinical and coaching services that our coin will deliver. Separately, we have a referral network on specifically how to cultivate those collaborative referral partnerships between the RHC and the pediatric RHC. And then last but not least are those business supports. How do you do scheduling, billing, clinical record creation, sustainability in this new model that nobody in our state has done? So we've done those things, and to codify all of this, because we're all under one umbrella of MUSC, we didn't have to have a business agreement or an MOA, but so that we had clarity of expectations, we created an informal expectations document so it was crystal clear who was doing what. So what's been great about this, and anytime I can quote Michael Scott from The Office, I try to, because he is a scholar of the modern era. I love this because he said, sometimes I'll start a sentence and I don't even know where it's going. I just hope I find it along the way. Because this has been derived from a rural community coalition that was specifically formed to address rural health inequities. We really have been led by them in a pretty organic way. This group, this coalition based out of Marion, without our influence, identified oral health inequities as their one priority. And so because the ground was already softened and there was political will to address changes in access to care, that made everything else that we have done very easy. We have not had to sell oral health and its importance in comprehensive health, nor have we had to sell it as it relates to well child development. So our next steps that we think, departing from Michael Scott's uncertainty of what comes next, what we think happens next now is, as we implement our change packages, we're working closely with Medicaid to figure out what does this look like from a billing perspective in the future. We want to be where Kelly is. We're following your lead, Kelly. We want to go where she is going. But as we do this locally, we have already formed the statewide learning collaborative with our public health, our organized pediatric guild, as well as Medicaid, to look at change packages that involve integration and the use of this model across rural South Carolina. And no more alarms have gone off, so that's a good thing.
Thank you, Kelly and Amy. And just as I kind of typed out there very quickly so I wouldn't forget, if anyone has any comments or any initial thoughts for some of the integrated features and pieces that Kelly and Amy talked about, please throw those in the chat. There was already one, I think Kelly already responded to it, but just in case, Kelly, Deborah was just asking any additional integration, or was there any integration between EDR and EHR? Kelly, I didn't know if you wanted to expand on what you responded to. I just want to give you the space to do that.
Sure. So, I mean, I will say that's definitely a tough piece, right? And we wish we had all of the answers there. We do have several systems that are now using Epic, and they've gone through conversions since we first started working with them back in 2016. Nobody has taken the leap to switch to Epic Wisdom yet. I'm told it's quite pricey. So sort of what they're doing in the meantime is still using, the Dentrix EDR, still using Epic on the medical side, but each side has access to the other's system. So they are able to look, and I would say that dental probably uses it a little bit more than the medical side does, but just to see, kind of to look at the whole picture of the whole patient, and to know what the medical side is talking about as the dental side plans for their care. So it's not a perfect system. Hopefully in time we will have a more perfect system worked out. But I think the bottom line there is unfortunately the cost of that integration.
Perfect. Thank you, Kelly. And Amy, I'm throwing you in a spot really quickly, but I wanted to ask about any current lessons learned or initial thoughts about Epic Wisdom in your academic center.
So we are, Kelly, just so you know, we're moving off of Axiom as a dental college onto Epic Wisdom. That full transition will occur this time next year. So we're under the 12-month mark right now. So as we're out right now, what we're doing is we're using the RHC's Epic, traditional Epic, to do all of her scheduling, because we have access to that since we are one MUSC. So our coin can see who is scheduled to come, because the RHC schedules the patients, not the hygienist. So she uses Epic to gain access to medical histories, physician notes of concern, risk assessment information, and the schedule. But the clinical documentation for dental and the billing is occurring separately into Axiom. We are trying to figure out now, as we are building our Wisdom interface, how Wisdom will communicate with the medical side of Epic. And it is sounding from our consultant that it will be an easy thing, but that is yet to be seen. What we did preemptively in Epic, though, is we built out, I think it's in the population health module, oral health prompts, as we helped all of MUSC tighten up their ability to be a patient-centered medical home and achieve those oral health standards. We built in some questions so that medical providers are tracking oral health. So we hope that this will merge well. Wisdom is definitely, at least it appears to be, fairly intuitive, but we'll see what rolls out in a year. So more lessons learned in a year is the bottom line.
That just means we have to come back and have a session on that. So I wanted to roll straight into our expert speakers and having them give us a little panel discussion on a few prompts. So they're going to serve as our two-woman panel for our time. So the first prompt is some of the things that you guys already discussed that you've seen over time. Just getting a better understanding of what has been just the end all be all impacts for rural oral health outcomes over the last decade as it relates to medical dental integration. Wanting to get, Kelly, both you and Amy's thoughts on how we have seen that interplay over time. And either one of you can approach this question first. I'll let you guys kind of decipher.
I don't want to step on toes, but I'll start. So I think, we've definitely seen a large number of patients address their oral health that probably would not have otherwise. And that was likely due to a conversation in the medical office about, the importance and the ties to overall health. And I think that there's generally just not a lot of knowledge around that. A lot of times the teeth are compartmentalized and it's just my mouth, just my teeth, and there's not that connection being made. So I think the more we have these conversations, the more primary care providers bring it up, the more patients are aware. We've also had a lot of communities really embrace oral health, and a lot of that has been because of the medical facilities, whether that's a hospital or a clinic or a group of clinics. We've had instances where there's involvement between the hospital and the local schools, and a lot of the medical providers will go out for Dr. Seuss Day and they will read a Dr. Seuss book to third grade classrooms. And so the year where we were really working on this medical dental integration, I said, well, what about the tooth book? And so they did. They took the tooth book out and they read that to all of the third grade classrooms that year. A lot of our RHCs also participate in the AAP's Brush Book Bed program. And so they made sure that there were some oral health related books on their bookshelves so that they were handing those out to patients. And so really taking the focus beyond just in the operatory and kind of expanding that out into the community to be able to make sure that oral health is sort of on everybody's radar. I do think we still have a ways to go. Was talking to a family member with a young child, and she was learning how to, she was teething, she was eating those teething biscuits. And I was like, all right, hygiene hat's coming on for a second. We're gonna have a little conversation and then I'll get off my soapbox. But the parent's comment back to me was, why hasn't anyone told us this? Why hasn't the pediatrician told us this? And so they seek care in New York State, not in Pennsylvania, so we can't blame any of my clinics. But we still have a ways to go with making sure that everybody's having this conversation. But I do think we've started to get it on the radar for a lot of folks.
And I can certainly think of some epidemiological points I could make, but Joni, if I could just keep it anecdotal for a moment, like Pennsylvania, South Carolina was a part of More Care, but before More Care, and I guess as a part of More Care, but before More Care, we had started another initiative called Roads. And that was specifically designed to improve collaborative referral relationships. So it was a focus on collaborative referral relationships between rural medical providers and rural dental providers. And we wanted to work with our private practice rural general dentists, because our FQHCs are exemplar in this space. So we knew they didn't need us, but rural did, or rather private practice did. And we had 3 pilot communities. And so to answer the question, what has been the outcome has been a really surprising expansion of access to care. And so in the case of these 3 practices, and we did this work almost 10 years ago, so I love the question, each of those practices have at least doubled. One now has tripled in actual access points, meaning they took one practice and were able to grow it because they got good at partnering with medical providers. And why that mattered is care outcomes for their patients that they had shared treatment goals on certainly improved. And by improving that, it increased capacity. So when you move people from disease management to maintenance, you can see more patients, number one. Number two, the calibration of expectation around seeing Medicaid especially really changed. Those providers, we increased capacity by 80% in those private practices to see Medicaid. So by helping them get better at identifying patients, being involved in patients, and creating efficiencies in how they schedule, bill, and partner, they've been able to see many, many more people, which has led to expansions. And when I canvass our state, I don't see rural dentists expanding their capacity to serve in the same way our three roads practices did. So in my assessment, we need more investments like that, because it's harder for you and I as dental faculty to recruit young dentists into rural areas. So we've got to create growth where we have some plants present.
Absolutely. Kelly and Amy, thank you for expanding on some of these outcomes and some of the more specific best practices. Kelly, as you mentioned, there's a lot of health literacy components there. Amy, there's some epidemiological impacts that we may not have seen otherwise. So I want to give the space for people if they have any questions for that kind of first dialogue to feel free to throw that in the chat or give me a hand raise there. But I want to keep the conversation lit while we've got it going here. This goes straight into COVID-19. So we literally cannot have any discussions moving forward without at least acknowledging some of the transformations that have happened just because of the nature of this pandemic. So we know that since the last Surgeon General's report, there's been a lot of things that have been aimed at elevating oral health as a national priority. But in this endemic and or era of COVID-19, how can, Kelly and Amy, how do you think that we as rural oral health advocates, if we're in the clinical space, translational research, how can we, that's the we, how can we maintain this oral health priority from a medical integration practice perspective as we move forward?
I'll take this one first. Kelly will trade off. I will say, in the case of many of the clinics that we work with on the medical side, we saw during COVID almost an exclusive use of telehealth. And while telehealth is wonderful for some things, in our state, it is difficult, though, to ensure early childhood growth and progression. And what we see in the Medicaid claims data, if you were 0 to 3 in 2020 and 2021, your well child visits dropped precipitously, as did going to the dentist. And so what our state is doing right now is working through our Medicaid as a partner, our Medicaid program, working with the state chapter of our Academy of Pediatrics to repurpose, re-elevate fluoride varnishing as a standard of care on the primary care side of the house, while we are coming up simultaneously as a dental school in partnership with Medicaid to recreate the magic of those practices I just described, so that we are raising our fluoride varnishing, we're raising oral health as a priority and reestablishing it as a part of comprehensive well child, but knowing that there's very little that we can ask primary care to do more of because they're exhausted. So we've got to deliver a dental system that's a true partnership to primary care. So I think now, at least in our state, it's a hot topic. There's a lot of energy on both sides of the system to do this and do this well. How we maintain that as a priority 3 and 5 years out, I don't know, because we certainly don't want complacency to set in. I think one thing that we can do is make sure, as a part of medical school, dental school, and appropriate residency programs in both professions, that we are teaching integration, we are teaching how to be partners and why those partnerships matter.
I agree with that, Amy. It's definitely, it's a struggle on both sides, right? From a capacity standpoint, from getting patients back into that routine of going to both medical and dental appointments. One other thing that we've been working on in our state is working with community health workers. And actually I have to buzz across town here a little bit later on today. They're having the first community health worker conference in the state. But all of our AHECs have done a lot of training with community health workers, and somewhere mid-pandemic, like this was probably a positive side effect of COVID, is all of these community health worker courses went into an online format. And so I now have the ability to meet with, even 2 groups in one day, because I didn't have to leave my house, to be able to do this oral health training with them. And so all of those AHEC community health worker courses now take 3 hours out of their curriculum to talk about oral health. And I think, honestly, I think a lot of them kind of come in a little grumbly, like, why do we have to spend 3 hours on teeth? This is ridiculous. And by the time they leave, I've had a lot of comments come back that have said, wow, I had no idea there was so much that went into this. And so I think continuing those conversations and having these kind of integration oral health conversations with folks that maybe we wouldn't have had otherwise, is just helpful in kind of spreading the word and keeping oral health, at least maybe not top of mind, but still in the spotlight to some extent.
Absolutely. And and Amy, you kind of touched on it a little bit, but I'm just picking on this just because of an enactment that happened in our state with the use of telehealth. Amy, can you talk a little bit about how you think the enhancement such as that? I know that we are not deploying that right now, but how can things like that be useful for medical integration moving forward? And if you could just do a little highlight on that enactment, Amy.
Sure. So we just did a policy analysis for our state Medicaid program. Teledentistry received temporary authorization when the public health emergency declaration went into place in March of 2020 for South Carolina. And so it authorized dentists to use telehealth to diagnose and triage and follow up with dental emergencies. It also authorized reimbursement by our state Medicaid program. When that went away, a year later, the authorization sunsetted. So it is the most bizarre place to be right now from a policy perspective, because our physicians can use intraoral cameras to do oral health screens and diagnose and bill, but dentists can't. So it's kind of strange. But we've got legislation in place. Our next session starts in January, and we've got intel to suggest that bill will see the light of day and be passed early in 23. What we learned from our policy analysis is that not a whole lot of exciting care happened necessarily using teledentistry, but what did happen was less than 2% of patients who had a teledentistry encounter ended up in an emergency room for a dental reason within 60 days of that encounter. So that was fantastic. But beyond that, 85% went on to receive needed services in a dental practice within 30 days. So telehealth for dentistry in South Carolina proved to be a great facilitator of getting people out of the healthcare system, or getting out of the medical, especially the medical emergency system, into appropriate places of care. We have equipped school-based programs, nurses, emergency rooms with intraoral camera, knowing that they can do things currently that dentists cannot, to use that technology to identify issues that should be addressed. So again, telehealth being used as a facilitator of appropriate access to care rather than just diagnosing. So it was a powerful lesson learned and really helped shape and inform this next generation of legislation that we hope sees 2023.
And if I may just jump in kind of to piggyback on that. So we are still able to use teledentistry in Pennsylvania. There's still, it's sort of like gray area, but we're taking it for what it's worth. And we've actually been able to work, one of our rural health clinics has been going out to Head Start programs and doing screenings of the children in the Head Start programs who probably have gone without care, especially through the era of COVID-19. The first day they went out, like they called me, my phone rang and I knew they were only halfway through their day. And I'm like, oh gosh, what's going on? So they send that public health dental hygiene practitioner out, and she's doing the screenings and some preventative services, getting that fluoride varnish on. The first child they screened had an active abscess, and they had been to the dentist recently, right? So the parents assumed everything was taken care of. And the tooth had been treated, but it was still abscessed, and that probably would not have been caught otherwise. And so meeting patients where they're at, trying to keep kids in school, parents at work after we've, sort of everything's been turned upside down for a couple of years is super important. And so they've been able to use teledentistry to their advantage, going out into the field. And then the dentist actually, so it's sort of store and forward, the dentist will actually sit down and review everything after the fact, after that day's over. And then they can come up with, a plan for each child, but that's been working really well in our state as well.
Amazing to hear these lessons learned and action plans around sustaining oral health as a public health priority, even in the midst of what we are seeing as just some delayed outcomes from COVID-19. I'm pausing here to do something that we normally don't do. Unmuting if there are any passion burning questions or comments for our excellent speakers. I'm just going to give a couple of moments for that. And if you had anything in the chat, I'm gonna take that time to scroll really quick. All right. Seems like all hearts and minds are clear, Kelly and Amy. What a rich and wonderful discussion on, things that you have experienced with medical dental integration. Our roundtable is geared at this threefold effort, whereby we want to see things happening for our rural communities in specific ways. So our first dialogue here today was medical dental integration. Our next roundtable will be facilitated in October, and we'll make sure that you all have the registration link for that, so that you can receive the right Zoom link, the right date and time, and making sure that we gather you back to have continued dialogue. I'm going to pause for a second because I think I see something in the chat. There is a question here, so let's make sure we address this. Moving forward, how can we keep the movers and shakers educated on oral health in our states? Kelly and Amy, I'm going to tap that back to you.
I'm going to put it back on LaShonda and say we need people like her on the ground who are in the clinics promoting it. So we can do policy reports and publish data and do all the things that we're doing, and that's wonderful. But in my experience, it is really promoting the model as something that improves health outcomes for patients, improves efficiencies within the care delivery system, and strengthens and addresses population health in a different way than what they do respectively. So I'd equip the LaShondas of the world to be the on the ground, in the clinic promoters and educators and technical assistance providers. That's how you do it.
Yeah, absolutely. Keep having the conversations. Don't let oral health come out of the conversation.
So clone LaShonda is
That's
what I heard.
right.
Okay. Well, folks, I'm gonna make sure. Thank you, LaShonda, for that question, and Amy and Kelly. I am dropping two things in the chat for everyone. I am dropping the rural NRT interest link. And I am also dropping the link for the next virtual roundtable. And that will get you in the door to make sure you have the right dates and times, as well as the right information for that roundtable. Kelly and Amy, thank you so very much for providing all of these lessons learned, some of the models, all of the information that they shared. We're going to make sure we send out to you, and their contact information will be available at Kelly and Amy, for them to answer any questions that you may have beyond our dialogue today. So thank you, everyone, for joining in. 8 minutes back on the clock. You all know I love to do that. So stay safe. I'm prayerful and hopeful that your families, coworkers, and teammates all stay safe during our season of hurricanes and all the things. But we look forward to seeing you at the next roundtable. Thank you, everyone.